Hello, everyone. I'm Shintalanka Vijayasinghe, and I will be presenting our research, cardiac MRI segmentation of ventricular structures and myocardium using unit variants. This research was conducted by Professor Dulani Mideniya, Dr. Pradeepan Yogaraja, and me. Cardiac magnetic resonance imaging has emerged as a powerful non-invasive modality to assess cardiovascular morphology and its function. It is considered the gold standard due to possessing an effective spatial resolution, which is crucial for assessing structures of small size. Segmenting ventricular structures and myocardium from CMR images is vital for understanding the cardiac physiology and aiding in the diagnosis and treatment of cardiovascular diseases. Cardiovascular diseases are known for one of the primary contributors to global mortality. Therefore, accurate segmentation of cardiac is vital for effectively diagnose the cardiovascular diseases. The anatomical structure of the cardiac comprises of three main significant regions as depicted in this figure. They are the right ventricle, left ventricle, and the myocardium regions. Extracting various quantitative measures such as right ventricle and left ventricle volume, ejection fraction, and so on becomes possible by segmenting the cardiac into these anatomically significant regions, which helps in diagnosing cardiovascular diseases. Manual segmentation of cardiac regions is done by skilled cardiologists. However, it is a time-consuming and a laborious task. On the other hand, the existing automated methods also face challenges due to brightness variations in cardiac cavities, presence of motion artifacts, variabilities in cardiac structures, and intensity variations. This shows the need for a fast, reliable, and fully automated segmentation technique for CMRI segmentation. The novelty of this study lies in conducting a comprehensive comparative analysis of 5 unit variants. All 5 architectures were refined and adapted as part of this research to address the challenges in CMRI segmentation. This study provides a direct comparison of the strengths and weaknesses of each architecture by training those using a consistent pipeline, which offers valuable insights. Finally, this study employs a custom hybrid loss function, which combines the cross-entropy and dice losses. The existing deep learning-based studies have employed different unit architectures for different stages of the pipeline, such as region of interest extraction and segmentation. These studies have utilized methods such as cascaded approaches, attention mechanisms, and hierarchical recurrent networks to achieve very high performances. Now let's deep dive into the methodology of this research. The overall process of CMRI segmentation consists of data pre-processing, data augmentation, model training, and evaluation as shown in this figure. The automated cardiac diagnosis challenge dataset, which consists of cardiac sign MRI scans, was used as the primary dataset for the study. It includes 150 patient cases with 100 used for training and 50 for testing. The dataset is divided into 5 balanced subgroups as depicted in this table, and it provides expert annotated segmentation ground truths at both in diastolic and in systolic phases. The images are available as 3D images in Nifty format. A sample 2D CMRI image with its ground truth is shown in this figure. As the first step of data pre-processing, 2D images are extracted from the 3D images. These images and their ground truth masks are then resized to 224 by 224 pixels to ensure consistent dimensions across all images and masks. Intensity normalization is applied to scale pixel values between -1 and +1 to enhance the model convergence and stability. The dataset is split in an 80-10-10 ratio, allocating 120 subjects for training, 15 for validation, and 15 for testing. Finally, to enhance the image quality, noise reduction techniques such as median filtering and Gaussian blur are applied. To improve model generalization and robustness, data augmentation was applied directly to the original 3D images rather than their 2D slices to preserve spatial relationships within the volumetric data. Augmentation techniques such as random rotations, flipping, motion blur, affine transformations, and elastic deformations were used in a controlled manner to prevent excessive variations that could lead to overfitting. Now let's deep dive into the proposed unit variants. The original unit architecture proposed by Ronneberger and others serves as the baseline model of our study. The encoder extracts features through convolutional and max pooling layers, while the decoder upsamples to reconstruct the segmented output. Skip connections enhance precise localization and efficient feature reuse, making unit highly effective for medical image segmentation. Several architectural enhancements were applied to the original unit baseline model. These include encode enhancements, improved skip connections, bottleneck refinements, rich representation techniques, and feedback mechanisms. Based on these modifications, different unit variants were developed, including residual unit, attention unit, feature pyramid unit, and feedback residual unit, each designed to enhance feature learning and segmentation accuracy for CMRI segmentation. The original unit and residual unit architectures were refined by adding more encoder and decoder levels. The attention unit was developed by integrating attention mechanisms into the skip connections and the bottleneck layers of the original unit. The feature pyramid unit enhances the original unit by integrating a feature pyramid block at the bottleneck stage for multi-scale feature extraction. The feedback residual unit was built upon the residual unit by introducing feedback connections. These connections enable the network to iteratively refine the segmentation outputs by revisiting and adjusting intermediate features based on the predictions. Now let's look at the proposed loss function for CMRI segmentation. Cross-entropy loss is a widely used loss function for multi-class classification tasks. It quantifies the difference between the predicted probability distribution and the ground truth labels, helping the model optimize its predictions by minimizing this difference. On the other hand, dice loss is designed for segmentation tasks to handle class imbalance and emphasize overlapping regions between predicted and ground truth masks. It computes a soft dice coefficient between the predicted softmax probabilities and one-hot encoded ground truth labels to measure the similarity between the segmented output and the target. As a novel contribution for CMRI segmentation, a custom hybrid loss function was developed by combining the cross-entropy and dice losses. The models were trained using PyTorch framework on an NVIDIA GeForce RTX 2080 Super GPU by using a batch size of 16 to balance memory efficiency and gradient stability. The initial learning rate was dynamically adjusted by using the reduced learning rate on Plato scheduler. To mitigate overfitting and improve generalization of the models, AdamW optimizer was used by separately penalizing large weights. Moreover, training was conducted for up to 100 epochs, with early stopping implemented to prevent further overfitting. This experimental setup ensured a computationally efficient training process while preserving model accuracy. Now let's look at the results of this study. As the main evaluation metric, dice coefficient was used to assess the performance of the 5-unit variants. It measures the overlap between the two sets, and its values spans from 0 to 1 with a perfect agreement indicated by a score of 1. The original unit demonstrated robust performance across all the categories, offering a strong baseline due to its simplicity and balanced design. The residual unit achieved strong performance, especially in right ventricle segmentation, where it recorded the highest dice score. The attention unit achieved good results, particularly in left ventricle segmentation, but lagged in right ventricle and myocardium segmentation. The feature pyramid unit achieved the highest dice scores in left ventricle and myocardium segmentation, demonstrating its superior performance. Its use of multi-scale feature extraction through the feature pyramid block likely enhanced its ability to capture both global and local information. The feedback res unit recorded the lowest scores across all structures, particularly for myocardium. While feedback connections aimed to iteratively refine predictions, their computational complexity may not have yielded significant performance gains, especially compared to approaches like feature pyramids. The segmentation results in this figure illustrate the performance of the 5-unit variants on 2 sample cardiac MRI images. In the first image, all 5 models achieved satisfactory segmentation outcomes, though the attention unit slightly undersegmented the myocardium region compared to the other variants. The second image highlights smaller, well-separated cardiac structures, emphasizing the need for precise segmentation. The original unit captured the general structure but showed boundary imprecision and failed to segment the right ventricle region. The residual unit and feature pyramid unit performed better, particularly in the right ventricle region. The attention unit focused well on the left ventricle but introduced small artifacts suggesting sensitivity to the input noise. Similarly, the feedback residual unit struggled with consistent segmentation as it undersegments the right ventricle region. Let's now compare the performance of the 5-unit variants with the existing state-of-the-art methods for CMRI segmentation conducted using the ACDC dataset. In left ventricle and myocardium segmentation, the feature pyramid unit achieved better die scores which are competitive with several state-of-the-art methods but fell short on the top-performing model proposed by Sharan and others. The residual unit scored the highest for right ventricle segmentation among the variants, surpassing feature pyramid unit, but both were outperformed by Sharan and others. While state-of-the-art complex methods may show high die scores, they often struggle with generalization due to overfitting to specific datasets, which requires extensive tuning. However, the proposed architectures are simpler and less computationally intensive than many state-of-the-art methods, making them more accessible and reproducible across different datasets and clinical settings. To conclude, this study conducted a systematic comparative analysis of 5-unit variants, incorporating refinements to the conventional unit architecture. The feature pyramid unit achieved the best overall performance across the 3 structures, demonstrating the effectiveness of multi-scale feature extraction for precise segmentation. The residual unit model performed well for right ventricle segmentation, recording the highest score among the variants. Last but not least, the proposed unit architectures offer valuable insights for future research, ensuring their continued relevance in both academic and clinical contexts. Thank you.